Thank you, Jennifer. Great way to start off the meeting, staying right on time. Perfect. And I expect everyone to follow through on that. So our next speaker for this session, and we're going to hold all questions now because we do have a panel discussion afterwards, so we can have 20 minutes worth of questions at that time. So our next speaker this morning is Dr. Mary Ann Johnson, and she is the Bill and June Flatt Professor in Foods and Nutrition at the College of Family and Consumer Sciences, and the Interim Director at the Institute of Gerontology at the College of Public Health, University of Georgia. She conducts research and outreach programs for older people to improve dietary habits, physical activity, and self-management of chronic diseases. She also studies centenarians, those aged 100 and older. And Dr. Johnson teaches courses in food and nutrition policy, chronic disease, obesity, and proposal writing. And graduates in her program go on to work in academia and government and as dietitians in nursing homes, healthcare, hospitals, and community health promotion programs. And again, her more detailed bio is in the book. Dr. Johnson?
Good morning. I really appreciate the opportunity to share some healthy aging perspectives, my perspectives, and also to learn from you today. Well, first of all, what is health? The WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I know many of us in nutrition usually think about health from the physical perspective, but it is much broader than that. Next, what is healthy aging? Well, part of it is living a long time, our lifespan, and this is the result of interactions between genes and the environment in which we live. And here environment, part of the environment we're talking about is nutrition and living a long time. So over the course of most of our lives, living conditions have improved. This has resulted in mortality decreases. There's evolutionary pressures for early survival and reproduction have relaxed, and we can direct further of our metabolic resources, our financial resources, into body maintenance and repair, and this then increases our average life expectancy and our maximum lifespan. Well, to be more specific, healthy aging involves reductions in the population level of mortality, morbidity, the chronic conditions we're going to hear a lot about over the next couple of days, mobility limitations, ADL limitations, which include eating, bathing, dressing, toileting, for example, the sensory changes, and seeing less of a decline in cognition. At the population level, we have a lot of different metrics of healthy aging, and there are just a few I've included here is life expectancy and healthy life expectancy. So healthy life expectancy is when we subtract the years lived in less than full health due to disease or injury. And if we look at this slide, we see age here. The blue bars are life expectancy at birth, and Jennifer showed some of that data already, and healthy life expectancy in yellow. If we go across the world in different regions of the world, and let's just focus on the Americas, you'll see there's about a 10-year gap between healthy life expectancy and overall life expectancy. So this is part of what we're trying to influence here. We can also look at healthy life expectancy at age 65. This is an interesting question to ask undergraduate students, because they're sure the only people over 65 would be their own grandparents. They're not aware of the very long life expectancy that we still have. So the darkest colors are states where the healthy life expectancy at age 65 is 15 or more years. So that would mean on average to 80 years. The states colored in white are less than 13 years more healthy life expectancy. And in some of those states, it's under 11. And what I find very interesting, well, sad actually, about this slide is when it's not corrected for race, ethnicity, income that we just heard a lot about, you see just considerable health disparities especially in the southern region of the United States. Well, the next thing I was asked to speak about was to start a discussion on biomarkers of healthy aging. And I used to think that these were only things you could measure in your blood. But when you're interested in older people, there is so much more that goes into a biomarker. It involves a lot about disease onset, progression, severity, physiologic, endocrine immune function, inflammatory responses, and then we have genetic markers, many different genetic markers. But what becomes increasingly important for older people and the people that care for them is physical and mental capability. We've already heard about concerns related to cognitive decline in Alzheimer's disease, health care, transitions of care. We talk a lot about maintaining independence, and that can mean a lot of different things, but usually what it means is an older person is still able to live in their own home and do things for themselves. It means avoiding a nursing home admissions and preventing hospital readmissions. So I'll talk a little bit more about those. Next, I want to give you some examples of the way different groups of investigators go about searching for biomarkers of healthy aging. And when you're thinking about what biomarkers are going to be the most important to you, whatever you're trying to do, design a new food, figure out some aspect of a disease process or a care process, it's a good idea to just know what was the rationale for these different approaches. So the first one is the cellular and animal studies. The next example comes from a group that's looking at biomarkers in the MarkAge study, which is coming to us from Europe. Ann Newman's group has looked at a longevity phenotype, a healthy aging index. We now have so many studies on predictors of mortality that we can do systematic reviews of cohort studies. And then the last one is the gerontology perspective that looks at functional, what we call in the geriatric field as functional markers. So let's first look at the cellular and animal studies. And the way to read this slide is to go across the bottom, and that is a depiction of middle age where we're starting to see the development expression of age-related diseases. Now remember, this is coming from a cellular and animal perspective. This group said, well, we're eating a lot of calories, we have eating a lot of protein, we have micronutrient deficiencies, so if we want to make it to the top of the pyramid, we need to balance our vitamins and minerals, reduce our protein, and practice dietary restriction. So about the time I put this slide together, a friend called and said, hey, I've got these really great studies in mice where I feed them low-protein diets, add a few amino acids. Looks really good. Let's translate that into people. And even the authors of this paper are very careful to say you have to be careful when you think about translating directly from animal and cellular studies. First of all, the human requirement for protein may be higher than current recommendations. There's a lot of research activity around this right now, so that's a very interesting story to follow. And secondly, there's a high prevalence of food insecurity in the very populations with the highest prevalence of chronic disease incidence, prevalence, and severity. So we just need to use caution when we try to make this leap from the animal studies to what may be the most important in people. Well, let's next move on to the biomarkers that are going to come out of the MarkAge study. And this study has a huge number of collaborators from across Europe. They have recruited over 3,000 people, and for a lot of different in a lot of different groups. So the first one would be people aged 35 to 74 in 5-year increments. And in this study, well, in most studies like this, if you're going to find out something unique about the oldest group of people, you need to know what's going on in the youngest group of people. They're also selecting people from long-lived families, sibling pairs, 90-year-old sisters or a 90-plus-year-old brother-sister. And then some people will undergo a longitudinal phase of the study. They also have small numbers of people with genetic disorders of accelerated aging, such as progeria. So this will be a really interesting study as the research comes out. So the first 6 to 7 different things they're looking at are pretty much what you would expect. You got to figure out how to recruit people, look at DNA, proteins, modified proteins, your immunology, clinical chemistry, hormones, markers of metabolism, oxidative stress, and then designing this kind of study in such a way that you can kind of do sweeps of the data and see what else is correlated to aging. And then with massive amounts of data, you need to figure out your bioinformatics system and then address all the ethical issues that come with knowing so much about so many people. So this will really be a study to watch as the data becomes available. Another approach is to develop a longevity phenotype and create what's called a healthy aging index. And here the researchers were interested in rather than a huge data set of potential biomarkers, what's kind of a minimum number that are very good predictors of mortality. And they're interested in heritable markers. So these data came from the cardiovascular health study, which is an ongoing study of CVD risk in about 6,000 people, 65 and older. And that's another thing to watch when you're looking at studies of this type is who are they recruiting? Is it a lifespan, or are they starting when people have already successfully aged to age 65? So they had quite a bit of data, and through a series of analyses, they found 5 indicators that were very good predictors of subsequent mortality. And that's systolic blood pressure, lung function, serum creatinine for kidney function, fasting glucose, and then a cognitive test known as a mini mental status exam. And when they put these markers together, they scored each domain, the 5 domains, as a 0, 1, or 2, based on tertile or clinical cutoff. So a maximum score someone could have would be a 10. And when they looked at the worst tertile versus the best tertile score, they found the mortality hazard ratio was about 2.62. So they felt that for people that wanted to look at aging, healthy aging, that you could do some pretty good, very good predictions with just these 5 indicators. So if you're in nutrition and you want to impact decrease mortality, if you can work through these variables, that may yield you some very positive results. So that's the way we think about this data. They went on to show in another data set the heritability of these conditions. And so we also need to start being mindful when we're looking at our favorite set of biomarkers of what's the genetic underpinnings. Nutrition can do a lot, but it's going to be working in concert with our genetics. Well, we now have so many studies of mortality predictors that we can do systematic reviews of cohort studies. And this team of researchers found about 23 studies that met their inclusion criteria, which were, it had to be blood markers, because they wanted something that would be relatively non-invasive that could be used broadly. And also the baseline sample age was 50 to 75. And a cheery little point of that study was that's how they defined middle age. So they're looking at people that made it that far, and see what can project, you living into your 80s, 90s, and 100s. And through the papers they looked at, they found over 50 biomarkers that looked like they had some potential. About 20 looked the best, including serum vitamin D, 25-hydroxy-D, but only a few could undergo meta-analysis because there weren't enough. There were only a few that had multiple studies, so they could do the meta-analysis. And these were the 3 that they found the most consistent with C-reactive protein, which is a marker of inflammation, the white cell count, and NT-proBNP. B is for brain. It gets complicated now. This particular protein is actually a very good index of heart function, heart failure, and things like that. So With this massive amount of data, these are the most consistent markers that they found for all-cause mortality. The last example I want to give you of how people search for biomarkers of healthy aging comes from John Mather's group in Newcastle. And they responded to a request from their Medical Research Council and did an extensive literature review. So you can see there's a lot of different ways. Some people are collecting primary data, some are reviewing the literature. They had a process where they could get a lot of feedback and conducted workshops. And their Medical Research Council's Population Health Sciences group was also overseeing their work. And they're really taking a public health approach here. And so they developed biomarkers of healthy aging in 5 domains. So by now, you're not going to be real surprised of what these domains are. Okay, so the first domain would be the markers of physiological functioning. And we're going to talk about a lot of these today and tomorrow. So cardiovascular function, lung function, glucose metabolism, and body composition. So these are very familiar to all of us in nutrition. The next would be the endocrine function, the HPA axis, sex hormones, and growth hormones. And if you've been in gerontology very long, there's always a lot of debate in that area. I don't really know what's going on there, but DHEA and cortisol are the main markers there. So again, nothing real surprising here, but very important. You know, this is what this group thinks are among the most important. And as nutrition and food experts, these are the ones that we want to target. Then the next one the third one is physical capability. If I had to pick out any of these, it would be physical capability and cognitive function are so important. And this is what aging specialists really look at. So strength, balance, dexterity, and locomotion. I'll just spend just a minute talking about balance. Having poor balance is a risk factor for falls. So 1 in 3 older people fall at least once a year. And falls are a leading cause of traumatic brain injury and hip fractures and other bone fractures. So this is huge. And I know many of us are trained more in the physiology, biochemistry area, and we're like, falls? What are you talking about? But it is so important. So if you go, for example, to the National Council on Aging website, they're working with Administration on Aging to develop and certify evidence-based programs for health promotion and disease prevention. There are so few studies of nutrition that are, made the cut. Lots of studies on fall prevention. And that will bring me to another point, is we really need to think what biomarkers of healthy aging are going to make the biggest impact. Okay, the next one would be biomarkers of cognitive function. And that's where we bring in our psychologists who have very good tests of memory, processing, speed, and executive function. So if we look at being independent, we can't be independent if we can't, think our way through our day and the things that we need to do. And then biomarkers of immune function is the 5th group, looking at inflammatory markers. So this is the different processes that have been used to identify markers. Well, where does nutrition fit in? Well, through biological pathways of aging, through disease prevention, treatment, and obesity that we're going to talk a lot about, meeting our current dietary recommendations. We saw the Healthy Eating Index already from Jennifer, and I'm just going to shout out 2 things on that index. Protein, we have so much research going on protein. We want to keep an eye on the benchmarks we use in that, and then we also are going to be relooking at sodium recommendations, so that may change. We also need to be mindful that we have a very large number of older people who are food insecure, so over 8% nationally and over 50% in some vulnerable subgroups, and that work comes from Jung-Sung Lee at the University of Georgia, who found a 50% prevalence of people on the home-delivered meal waiting list in our state. So as we search for what's a healthy biomarker of aging, we also need to make sure that people are well-nourished and can benefit from that. Nutrition interventions for biomarkers used in healthcare is something I want you to think about through care transitions, readmissions to hospitals, and rehab facilities. We've got a new faculty member at the university who was chief information officer of a huge healthcare system in North Carolina, and he says, oh, what you need to be looking at is affordable care organizations, quality care measures. I said, what are those? He said, oh, there's about 40 or 50 of them. So send me the list. I said, oh, wow. So I pulled out a few that are nutrition and gerontology related: depression, hemoglobin A1C, blood pressure, heart failure, CVD. Looks familiar. Healthy biomarkers of aging. So we could really be a part of the national conversation if we start thinking like health economists and how we can impact these kind of variables. Another important area to look at is where nutrition fits in what we call care transitions. So people want to be independent living, but things happen. They end up in acute care or long-term care. We have the social services that are called home and community-based services, and a big part of that is meals. There's many other services that can be provided, and there's a national conversation going on, hopefully community conversation going on, is how can the medical health system and the social services health system work together, and one of the big links is the meals, because you can just be discharged from the hospital, bump right back home, and not have the meals you need. So a lot of conversations there. We're going to hear more about obesity as well. Even my graduate students think, well, I guess obesity is so bad. If you have that, there are no old people who are obese. It's like, no, that's actually where we still see the prevalence of obesity increasing. And we know that obesity can accelerate aging through increasing the risk for many age and obesity-related chronic diseases. And we have good evidence that diabetes and obesity are risk factors for early admission to a nursing home. So we really need to be mindful of that. So let's just wrap up here. Biomarkers for food, nutrition, and healthy aging will certainly be in our major cardiovascular, renal, lung function areas, cognition, physical capability, and we need to think about how to identify the nutrition interventions for costly biomarkers. So think like a health economist for during care transitions, readmissions to hospitals and other health services, and affordable care organization quality care measures like diabetes and CVD. Thank you.